Today we talk about bronchiolitis in children essentially, and also we'll talk about preventive measures in adults. The goal of the presentations are two. One, better understanding of the disease process, treatment of bronchiolitis utilizing an evidence-based medicine. Bronchiolitis is defined as a clinical syndrome of respiratory distress. It's seen in infants usually less than 24 months of age. Bronchiolitis is characterized by upper respiratory symptoms followed by lower respiratory tract infection with inflammation. It results in wheezing and or crackles. It lasts for about 3 to 4 weeks. It's usually caused by a viral infection. RSV is the most common cause, followed by rhinovirus. Other viruses causing bronchiolitis include parainfluenza, human metapneumovirus, influenza, adenovirus, coronaviruses, and human bocavirus and enterovirus. As you can see, the article published in a New England Journal of Medicine, 50 to 80% of the isolates are RSV A and B. It's often isolated between November and April. Bronchiolitis typically affects children less than 2 years of age and occurs during fall and winter seasons. Hospitalization for bronchiolitis has a peak incidence between 2 and 6 months of age, but remains a significant cause of respiratory disease for the first 5 years of life. Bronchiolitis continued to be the leading cause of hospitalization in infants and young children. Let's look at the global prevalence published in Lancet 2022. I'd like you to focus on these two columns, developing countries and industrialized countries. It is separated by different ages. I want you to look at 0 to 5 years of age. As you can see, the incidence of disease is 31.5 million disease children are affected in developing countries versus close to 1.5 million in industrialized nations. They're almost 20 times higher in developing countries than industrialized countries. When you look at the mortality, this mortality attributable to RSV in children affected with RSV can have a disease attributable to RSV and also the death attributable to other coincidences like secondary bacterial infection, sepsis, so on and so forth. If you look at RSV related mortality, you can see 900 deaths in industrialized countries altogether, but in developing countries 100,000. There is a 10 times, 1,000 times, is that right? Yeah, 10 times higher incidence of mortality, while the incidence is only 20 times of industrialized nations. So what are the risk factors for having a severe disease with RSV? Infant of multiple gestation of pregnancy, prematurity, low birth weight, less than 12 weeks of age, that means less than 3 months of age, BPD or chronic lung disease, anatomic defects of the airways, hemodynamically significant congenital heart disease, immunodeficiency, neurologic disease like cerebral palsy, congenital anomalies like Down syndrome, absence of breastfeeding, birth date 2 months before and after the start of epidemic, lower socioeconomic group, malnutrition, crowded living conditions, passive smoking, and attendance of daycare. If you want to remember the most important risk factors, remember hemodynamically significant congenital heart disease, chronic lung disease of prematurity, otherwise called BPD, history of prematurity, immunodeficiency, and low concentration of maternal antibody. The disease progression occurs like this. Child inhales the droplets. After 4 to 6 days of incubation period, the child develops fever, congestion, rhinorrhea, irritability, and poor feeding. 2 to 3 days after the onset of URI symptoms, develop develop the infection in the lower respiratory tract. About 30% of them develop lower respiratory tract infection that's called bronchiolitis. They present like cough, tachypnea, wheezing, grunting, nasal flaring, and thoracic retractions. Hyperinflation of the lungs develop because of the air trapping and the occlusion of bronchioles. Air trapped in alveoli is absorbed, resulting in localized atelectasis distal to the obstruction. It causes increased workout breathing, a decline in lung function, and also mismatching of the ventilation perfusion, resulting in hypoxemia. Most of these patients present with fever of 101 to 102. The next important symptom is cough, but one has to remember cough reflex is relatively absent in neonates and does not mature until after 1 month of age. They all will have respiratory distress, meaning increased rate, retractions, wheezing, and crackles. These symptoms are often preceded by 1 to 3 day history of URI symptoms like nasal congestion and discharge. And history of exposure to viral URI either in the daycare center or other siblings at house. Most of these kids do have a diminished oral intake. Other symptoms include tachypnea, the rates as high as 70 depending on the age. Some children do have apnea, especially the neonates, and history of prematurity. They tend to have low saturation. Based on the saturation, they are subdivided into 3 categories: mild, moderate, severe. The saturation is more than 92, they fall in the category of mild. When the saturation between 88 to 92, they fall in the category of moderate, and severe ones will have less than 88 on room air. They tend to have tachycardic because of the fever, workout breathing, and also because of poor feeding. They tend to have intercostal retractions, wheezing, crackles, and diminished breath sounds, and some of them will have prolonged expiratory phase. Most of them are very irritable, and they will have profuse mucous nasal secretions and dehydration as a result of poor intake. So one has to consider other differential diagnoses like recurrent viral triggered wheezing, bacterial pneumonia, pertussis, chronic pulmonary disease, foreign body aspiration, aspiration pneumonia, gastroesophageal reflux, congenital heart disease, heart failure, vascular rings. What is the usual clinical illness? Typically begins with URI symptoms, followed by lower respiratory tract symptoms on days 2 to 3 of illness, and peak usually happens 3 to 5 days of illness and then gradual resolution. Children not required hospitalization recovered by 28 days. The median value is 8 to 15 days. The wheezing can persist in some infants for a week or longer. With the exception of otitis media, secondary bacterial infection is uncommon. Most with mild to moderate degree can be managed as outpatients with supportive care. Inpatient treatment is supportive care with supplemental oxygen, fluids, and respiratory support with suctioning and high flow nasal cannula. In severe cases, they may need even intubation. The complications during acute illness include dehydration, apnea, respiratory distress progressing to respiratory failure. Almost 10 to 20% of the infants develop significant respiratory compromise, especially those who have underlying BPD or congenital heart disease with hemodynamic significance. Bacterial co-infection can occur, and acute otitis media being the most common. The bronchiolitis occurs when a virus infects the terminal bronchiolar epithelial cells, which causes damage and inflammation in the small bronchi and bronchioles. As a result, it causes edema, excessive mucus, and sloughed epithelial cells, lead to small airway obstruction, air trapping, and atelectasis. The pathologic changes begin 8 to 24 hours after the infection that include bronchiolar cell necrosis, ciliary disruption, and peribronchiolar lymphocytic infiltration. I want to show you it in pictures so that it's easy to understand. The infection happens in the upper respiratory tract first. One third of the children develop lower respiratory tract infection. The nasopharyngeal cells are slapped and aspirated, carrying RSV to lower respiratory tract. Then viral replication results in epithelial cell sloughing, inflammatory cell infiltration, edema, increased mucus secretions, and impaired ciliary action. Sloughing of RSV infected epithelial cells into the lumen accelerates viral elimination but also contributes to obstruction of the airway. Absorption of trapped air in the alveoli distal to the obstruction leads to localized atelectasis. This is the respiratory score system we follow in our hospital. It has 4 components of scoring system from 0 points to 3 points. 0, 1, 2, 3. We use 4 parameters to have the assessment done. Right, rate depends on the age, retractions, dyspnea, and auscultation. So when there is no retraction, 0 points, subcostal, intercostal, 1, and 2 of the following, subcostal, intercostal, substernal, or nasal flaring, and give 2 points. If you have 3 of the following, and you get 3 points. Dyspnea, normal, 0 points. Difficulty feeding, decreased vocalization or agitation, 1 of the following one of those will carries 1 point, 2 of those carries 2 points. In when the children are stop feeding, there is no vocalization, drowsy, confused, they automatically get 3 points. In auscultation, end expiratory V's, 1 point. Expiratory V's greater than end expiratory. More expiratory V's in 2 points. Both inspiratory and expiratory V's are diminished breath sounds, carries 3 points. Based on the respiratory scoring system, we group into 3 categories: mild, moderate, and severe. Mild, the scoring 1 to 3, moderate 4 to 8, and severe 9 to 12. The max is 12. So assessing the severity is very important, so that we can the rapidity of intervention and allocation of resources. As you can see, the mild respiratory distress often needs just a nasal section, reassess if the child does well, and send them home. Moderate can go either way. Do the nasal suction, IV fluids, oral fluids. If the child gets better and can be discharged, or observe in the emergency department and sent home later, or get admitted. Severe, we escalate the care from right on. so that they will invariably end up in the hospitalization, either in the pediatric floor or in pediatric ICU. In this particular slide, I want you to focus on this particular the red box. What are the signs of clinical deterioration? Lethargy despite noxious stimuli, inappropriately low respiratory rate or worsening obstruction, apnea, poor perfusion, deterioration does not correlate with the day of illness, because the first 3 days they usually get worse, then they remain stable and they get better. So you have to kind of keep what is the day of illness so that you can um, get an idea. Are we expecting things get worse before it gets better? This pathway includes the inclusion criteria 2 months to 2 years, and history and exam consistent with bronchiolitis. If the patients have hemodynamically significant congenital heart disease, anatomic airway defects, chronic lung disease, neuromuscular disease, immunodeficiency, they tend to do worse. So escalate the care from early on, meaning placing an IV or NG feeds and place them on heated high flow and admit them without wasting time in emergency department or ambulatory care unit. The tests such as we used to use in bronchiolitis, like albuterol, epinephrine, hypertonic saline, steroids, antibiotics, chest physiotherapy, chest x-rays, and viral studies, they have not been shown to be helpful in treating this kind of patient. Consider chest x-ray only when there is a persistent focal exam findings, airway complication, worsening conditions, and presence of new murmur. There is no known treatment. There is no known treatment shortens the course of illness or hastens the resolution of symptoms. Relief of nasal congestion by suctioning. We will go in detail in subsequent slides. And make sure the patient hydration is good, either orally or nasogastric tube or IV fluids. Give oxygen when there is hypoxemia. Nutrition support early on, either by mouth or via nasogastric tube. And fever control is very important. And if the patient has a respiratory distress or pending respiratory failure, early initiation of high flow nasal cannula or sometimes intubation. All care is dependent on the respiratory score. So respiratory score is very important to categorize them into mild, moderate, and severe. This is the latest American Academy of Pediatric guidelines. I want to kind of focus on those with the positive or truly recommended. All others are not recommended as of 2016. So when to give supplemental oxygen? When the saturation is less than 90, go ahead and start supplemental oxygen. If the saturation is more than 90, they do not need. Second, nutrition and hydration. Because these children have a poor oral intake and rapid respiration or tachypnea, they often have dehydration. So having IV fluids and bolus, if they are moderate and severe, sometimes make sure the oral intake is good enough. If it is not, place the NG tube and ensure the hydration and nutrition is maintained. If the symptoms doesn't improve and stayed in the hospital more than 3 days, one can consider nebulized hypertonic saline. This particular slide showing it is so small. Apologies, because it's kind of hard to accommodate all the how many 6 guidelines in one slide. There are multiple guidelines. The first one being Australia and New Zealand, second UK, third is United States, Canadian, Italy, France, and Spain. There are subtle differences between these guidelines. I wanted to spell it out to you. Urine microscopy and urine analysis. And United States not recommended, UK and except Spain and Australia, New Zealand guidelines. They consider if the patient is less than 2 months and have a temperature more than 38, one can consider doing urine analysis and urine culture. The second page, suctioning, and let's start with United States. United States guideline says there is insufficient data, but the usage of deep suctioning is not helpful. That's how they left it. I really like the way the Canadians um, mention it. Superficial suctioning is recommended in patients with bronchiolitis. Deep suctioning and prolonged absence of certain suctioning should be avoided. I like that language better than any other guidelines. So I agree with that part. Heated high flow nasal cannula, since the guidelines came in around 2016, 2014, and 2010, and it's not much a heated high flow was used at that time. So the people are not very sure. Some of them said experimental, so on and so forth, can be considered, so on and so forth. And regarding supplementation of oxygen, everyone agrees if there is a hypoxemia, go ahead and start supplemental oxygen. Regarding hydration, nutrition, everybody agrees. Either make sure pure intake is good, if it is not, nasogastric, if it is not, IV fluids. Let's move on to the bronchiolitis care, supplemental oxygen. Supplemental oxygen should be provided if saturation falls persistently below 92 in ages of 6 weeks and under, and 90 or ages 6 weeks and older. Oxygen is supplied via nasal cannula using the lowest flow possible. Deeper, self-resolving desaturations may not be clinically meaningful in mild to moderate bronchiolitis patients, who should therefore be taken off continuous pulse oximetry once off supplemental oxygen. Suctioning. Suctioning is not widely evaluated in the literature but is considered essential in bronchiolitis care. Used to clear secretion from the nares and airway that the child is unable to clear him or herself. It induces coughing, which allows child to clear lower airway secretions, reduces overcough breathing, and improves oral intake. Suction gaps may be associated with longer length of stay. Patient admitted with bronchiolitis should receive suctioning of the nares at frequent intervals, at least every 4 hours, and before feeding and sleep. Nasal suction with with an olive tip catheter or bulb. We want to make sure it doesn't cause that much of edema or irritation, should be used routinely. Nasopharyngeal suction should be used in patients with severe distress and fail to improve with olive tip suction. Nasal edema may result from repeated nasopharyngeal suction, so it should limit only in very severe situation. Otherwise, gentle suction of nares alone is good enough as long as it is done in a periodic intervals without leaving big suction gaps. Respiratory scores and suction response should be documented before and after all types of suctioning. Families should be trained on how to use nasal suction at home. Nasogastric or IV fluids. Intravenous or nasogastric fluid administration should be considered if the patient cannot maintain hydration orally or is severely dehydrated. Nasogastric hydration is as effective as IV hydration in patients with bronchiolitis and requires fewer attempts at placement. It is advisable to involve caregivers in the decision of how to hydrate their child. Because respiratory distress may increase the risk of aspiration, patients with significant coughing, choking, gagging, and worsening tachypnea with feeds should be made NPO, and IV-NG hydration should be started. Patients with sustained respiratory rate more than 60 should be evaluated for safely with feeding trial. If severe distress happens, do not attempt feeding trial and make NPO. Patient with high flow nasal cannula at floor maximum rate should be NPO. The end result of inflammatory insult is increased secretions, air trapping, atelectasis, hypoxemia, hypercapnia, acidosis, and increase in respiratory effort, dehydration due to decreased PO intake. Thus, the need for intervention to occur when there is a worsening of any of those happens. How do you treat? Treat with high flow nasal cannula. Let's go with this algorithm. It's published 2 years ago. Child admitted to the hospital with bronchiolitis. Commence supportive care for feeding or fluids. If the patient is not hypoxemic, observe respiratory status. Does the infant have severe respiratory distress? If it is yes, escalate the care. If it is no, observe and discharge the patient. If the patient is hypoxemic, start low flow oxygen. If the patient respond, wean, titrate and wean, and possible discharge. If the patient does not respond, start high flow nasal cannula at 2 liters per kilogram per minute and titrate FiO2. If the patient responds, titrate FiO2 to room air. Once stable in room air, stop high flow. Do not titrate flow. If the patient does not respond, according to this algorithm says nasal CPAP, but in United States we move into ram cannula or intubation. Personally, I do ram cannula before intubate. Vast majority of the patients easily can be managed with ram cannula ventilation. Nasal CPAP does not work. So what is heated high flow nasal cannula? High flow nasal cannula is not just standard nasal cannula turned up to high flow rates. High flow nasal cannula, where the gas is heated at up to 37 centigrade with 100% relative humidity, it can deliver room air all the way to 100% FiO2. The flow rates can be titrated up to 60 liters per minute. The flow rate and FiO2 can be independently titrated based on patient's flow and the FiO2 requirement. So how does it work? Number one, it gives heated and humidified flow. It improves secretion clearance, decreased airway inflammation, and also decreased energy expenditure. It also increase sorry it sorry it match up with the patient requirement, meaning the peak inspiratory flow in normal individual is 30 to 60 liters per minute is an adult value. It can reach up to 120 liters in patients with acute renal failure. Having higher flow, it matches up with the patient requirement. It improves functional residual capacity. And also it's lighter, meaning having CPAP and BiPAP needs facial mask. Usually the small children do not tolerate or like it. So what is oxygen dilution? I like to explain in a couple of slides. When you give a regular nasal cannula with 1 liter flow, it gives 25% FiO2. As you increase the flow, the FiO2 goes up by 4. That is called 4 to 1 rule. For example, 3 liters, you add 2 times 4 is 33, and 4 liters, 37%. Let's look at, you are giving 6 liter nasal cannula at 45%. The peak inspiratory flow of the patient is 20 liters. What is the chance of having FiO2 close to 45% in the trachea? It's nil, because the peak inspiratory flow through the mouth is 20 liters at 21%. So most likely the patient is only getting only 21%, even though you are giving regular nasal cannula at 45% at 6 liters. On the other hand, if you give a high flow nasal cannula at 60 liters at 45%, the peak inspiratory flow through mouth, via mouth, is only 21% room air. So what is the chances of having FiO2, the FiO2 concentration in trachea? Most likely it's close to 45%, because the high flow nasal cannula ensures the FiO2 being delivered into the lungs. As a result, high flow is far superior. It negates the oxygen dilution effect. What are the other mechanism of actions of high flow nasal cannula? Number one, it meets inspiratory demands, because inspiratory demands, even the normal healthy volunteers, it's 30 to 60 liters per minute. Number two, it decreases oxygen dilution, as it was explained in those previous 3 slides. And lighter, because it is just a nasal cannula. Even the nasal cannula, children do not like it, but it's much better than having a mask over the face. It increases the functional residual capacity. And finally, it causes dead space washout. What is dead space washout? So when you breathing, normally, when you breathing, you inhale normal air, atmospheric air with 21% oxygen. When you exhale carbon dioxide. When the subsequent breath, not only you inhale the atmospheric air, and also you inhale the expired air. So 1/3 of the inspiration includes the previously exhaled carbon dioxide. In patients on high flow nasal cannula, it removes that one, because the higher flows, it blows out carbon dioxide. So that is called dead space washout. This is the first randomized control trial, as I know, comparing regular nasal cannula and high flow nasal cannula. It's a multi-center study done in Australian and New Zealand pediatric ICU and inpatient. As you can see, the high flow oxygen therapy patients had lower failure rates than the regular nasal cannula patients. As you see in the results, there are 12% of the patients in high flow group needed escalation. The regular nasal cannula group, which is standard therapy group, 23% needed escalation. That means 23% failed in regular nasal cannula group, only 12% in high flow group. And the p-value is very significant, as you can see, less than 0.001. So high flow nasal cannula clearly wins the race here. Caregiver education is very important, since the symptoms and signs last for about 20 days, 3 to 4 weeks. So the caregiver family teaching begins at admission in inpatient and also discharge from emergency department. So teach them about signs of respiratory distress, how and when to nasally suction, maintain hydration by small frequent feeds. What are the things you need to look for? Signs of dehydration. And also anticipatory guidance, like cough can last up to 4 weeks. Do not use over-the-counter cough and cold medicine. and make sure hand hygiene is followed. Otherwise, this virus can spread to other children in household and also in daycare center. Finally, how to protect infants and children. Fortunately, we have RSV antibodies available for babies and some young children to protect them from severe RSV. And also, maternal vaccine is available for pregnant mothers at weeks 32 to 36 of pregnancy to pass on protection to their baby. Okay, when to give the vaccination? CDC recommends nirsevimab, that is monoclonal antibody against RSV G proteins, recommended from October 1st all the way up to March 31st. The maternal vaccine called Abrisvo, recommended during week 32 to 36 weeks, which is 1 month prior, September all the way to the February, because it produces antibody 14 days after the vaccination. So who needs to get vaccinated? All infants younger than 8 months of age, born during RSV season or entering their first RSV season, should get immunized. Except in rare circumstances, most infants younger than 8 months of age do not need nirsevimab if they were born 14 or more days after the maternal vaccine. If the mom got a vaccine, only those children do not need, otherwise everyone else. They also the mom need to be given a vaccination 14 days prior to the birth. Some children between 8 to 19 months who are at increased risk of severe disease and entering their second RSV season can get near the RSV vaccination. So what are those risk factors? Children who were born prematurely and have chronic lung disease. Children with severe immunocompromise. Children with cystic fibrosis who have severe disease. And also American Indian and Alaska Native children. How does nirsevimab work? The commercial name is called Beyfortus. Nirsevimab reduces the risk of severe RSV disease by about 80%. One dose protects infants for at least 5 months, the length of an average RSV season. Because nirsevimab does not activate immune system, protection is most effective in the weeks right after nirsevimab is given and lessens over time because the effectiveness wanes over time. This is a study done in Europe, Luxembourg in particular, because the nirsevimab was approved first in Europe, second in Canada, just last year in United States. So they did vaccination in 2022. Look at the results. As you can look at the results, prior to nirsevimab, just concentrate on the age in months, 0 to 2 months. Hospitalization was 150 plus prior to vaccination. After vaccination, it's reduced to 50. As the age advances, you didn't see a huge difference. The reason is we may immunize only children less than 8 months of age. It is a telltale evidence that this vaccination works, reduces the hospitalization. What about vaccine for adults age 60 and over? This is from CDC guidelines. There are 3 RSV vaccines licensed by the US FDA for use in adults aged 60 and older in the United States. CDC recommends all adults aged 75 and older should get an RSV vaccination. And also it recommends all adults between 60 and 74 who are at increased risk of severe RSV disease. So what are those 3 vaccinations approved in the United States? Number 1, GSK's Arexvy, Moderna's Remdesivir, Pfizer's Abrysvo. These vaccines work by causing an immune response that can protect you from respiratory disease if you get RSV in the future. So it's an active immunization. It's not like nirsevimab. Who should get vaccinated? As we mentioned before, all adults aged 75 years and up, and adults between 60 to 74 years old with increased risk. So, what are the increased risk factors? Have a chronic heart or lung disease, have weakened immune system, have certain other medical conditions including severe obesity and severe diabetes, living in nursing home or other long-term care facility. And RSV vaccine is a single dose vaccination. It is not an annual vaccination as of now. So how long these vaccines work? Adult vaccines. GSK's RSV gives a protection up to 2 years. Abrysvo of Pfizer shown to provide protection for up to 2 years. Moderna's Remdesivir gives protection up to 1.5 years or 19 months. The reason we have a shorter time because these vaccines has been licensed by FDA in May 2023, RXV and Abrysvo, Remdesivir just a couple of months before, like June 2024. So we don't have enough evidence to see how long the effectiveness lasts. As it stands now, around 2 years. Well, that concludes the talk on bronchiolitis. We do give seminar every Sunday at 7:30 a.m. Central Time, 6 p.m. Indian Standard Time. Thanks for watching, and we'll meet you next week.